Hello, my name is Jennifer Danieli, and this PowerPoint is on a differential case presentation. My case study is regarding a patient who is a 28-year-old woman with an opioid use disorder, currently using IV heroin. She has a history of post-traumatic stress disorder, and no other medical problems or medications were identified. She currently is single and lives with several roommates. She has a history of legal problems, including spending time in jail. She is sexually active with both men and women and is inconsistent with using protection. She comes to the office complaining of the following symptoms of shortness of breath, chest pain, flank pain, and fever. Patient demographics are that she is a known IV heroin user. She lives with several roommates and has experienced legal problems as well as spent time in jail. She also has a history of multiple sexual partners and having unprotected sex. The three differential diagnoses that I've chosen are pneumonia, tuberculosis, and opioid overdose. After researching the differential diagnoses of an IV heroin abuser, the diagnoses that were chosen were due to the patient's active IV drug use. The patient may also have a weakened or immunosuppressed immune system after being exposed to a different environment in jail as well as her IV drug use. The first diagnosis I'm going to review is pneumonia. The pathophysiology of pneumonia is an infection that causes inflammation in the alveoli in one or both lungs. The air sacs may fill with fluid or pus, causing cough with phlegm or pus, fever, chills, and difficulty breathing. Depending on the infection agent, the pneumonia can be bacterial, viral, or fungal. In most cases, the organism enters the lungs directly by inhalation, resident bacteria spreading along the mucosa, or aspiration in secretions. According to the Mayo Clinic, signs and symptoms of pneumonia include chest pain when you breathe or cough, cough which may produce phlegm, fatigue, fever and shaking chills, nausea, vomiting or diarrhea, and shortness of breath. The diagnostic tests I would order is a chest x-ray, blood work including a CBC, SMA6, as well as a sputum culture if I was able to obtain it. My treatment plan would be to treat with a broad spectrum antibiotic, a nebulizer treatment depending on the respiratory status of the patient, a cough medicine, as well as Tylenol for fever. And I would also make a community referral to a pulmonologist to determine if there were any complications or residual effects from the pneumonia. The second diagnosis I'm going to review is tuberculosis. The pathophysiology of tuberculosis is an infection that is usually caused by Mycobacterium tuberculosis and primarily affects the lungs, but the pathogens may invade other organs as well. There are two stages of tuberculosis. The first stage is called the primary infection. That is when macrophages immerse the microorganisms when it enters the body. This causes a local inflammatory reaction in the upper lung. A granuloma develops at the inflammation site when the lymphocytes and macrophages cluster together. As long as the individual's resistance and immunity responses remain high, the bacilli remains walled off within the tubercle. The primary infection indicates that the patient does not have an active infection, but that they have been exposed and are infected with the bacillus. The second stage of tuberculosis is the secondary infection. This occurs when the tuberculosis becomes active. This can occur several years after the initial infection and is usually caused when the patient's immune response decreases or they have been exposed to the microorganism for a second time. Patients with primary tuberculosis are usually asymptomatic. Those patients that have secondary tuberculosis usually have a low-grade fever and night sweats, anorexia and weight loss, chest pain, dyspnea, prolonged cough, purulent sputum which may contain blood, as well as fatigue and malaise. The diagnostic test that I would prescribe for a patient that I felt had tuberculosis would be a chest x-ray, an acid-fast staining of sputum, a CAT scan, C-reactive protein, quantiferon blood test, as well as a tuberculosis test. The treatment plan. According to Reinmark and Lardizabal, tuberculosis is nearly always curable if patients are treated with effective, uninterrupted anti-tuberculous therapy. The primary medication regimen lasts between 6 months to a year, and that medications would be rifampin, rifampentine, and isoniazid. I would also make a community referral to a TB clinic to provide ongoing medication monitoring as well as education. The last diagnosis I chose was opioid overdose. The pathophysiology of opioid overdose is that illicit drugs used to get high may be taken with overdose amounts when a patient's metabolism cannot detoxify the drug fast enough to avoid unintended side effects. Patients with opioid use disorders typically have impaired social functions, which in our clinical experience can vary widely in association with the severity and duration of the disorder. According to Goldberg, the following are possible symptoms of an opioid or heroin overdose. There could be problems with vital signs, temperature, pulse rate, respiratory rate, and blood pressure, all possible and can be life-threatening. Vital sign values can be increased, decreased, or completely absent. The patient can be sleepy, confused, or in a coma. The skin could be cool and sweaty or hot and dry. Chest pain is possible and can be caused by heart and lung damage. Shortness of breath may occur. Breathing may be rapid, slow, deep, or shallow, and they also may experience abdominal pain, nausea, vomiting, and diarrhea. The diagnostic tests that I would order would be blood work, including a toxicology screen, complete blood count, and liver functions. I would also order a syphilis and tuberculosis test, as well as an echocardiogram. The treatment plan for a suspected opioid overdose would be to call 911 immediately and administer naloxone. The community referrals that I would make would be to Planned Parenthood to provide education on having protected sex, to a counseling center to provide education on HIV testing, as well as an outpatient methadone clinic to provide education on IV drug use and transition to using methadone in place of IV heroin, and possibly if the patient was open to an inpatient rehabilitation center to provide treatment and ongoing counseling for the IV drug use. In summary, the diagnosis I feel that is most likely the culprit for my patient's complaints is tuberculosis. Her lifestyle puts her at risk to be exposed to tuberculosis from spending time in jail to using IV heroin, as well as having unprotected sex. The case study gives limited information, and I feel myself thinking of the worst scenarios this patient could experience. My original differential diagnoses included substance withdrawal, pneumonia, and anxiety disorder due to her post-traumatic stress disorder. After completing my research, I found additional information that led me to choose pneumonia, tuberculosis, and heroin or opioid overdose. This last slide is a list of my references. Thank you, and I hope you enjoyed the presentation.